Good afternoon, everyone. It's a pleasure to be able to talk a little bit about physician interventions when it comes to pain management in the outpatient setting. You've probably had a very long day today so far. I'll do my best to be witty and actually spend a little bit of time being useful. I'm sorry I can't be there in person. I'd love to answer your questions, but I'm going to be in Texas at the AAPM&R conference, where hopefully I learn a few more things about this and I can bring them back to Southern Illinois. So my role in the outpatient setting may seem obvious, but it's not. In fact, I end up spending an awful lot of time doing all the same things that each one of you does. I just get to reinforce all the great hard work that you do. So the challenge that we all have is, what is the pain generator? Patients have a great deal of difficulty explaining exactly what the pain generator is and what their problem is. They'll like to give us diagnoses. They'll like to tell us stuff that they've been told. They'll like to tell us what they've read on the internet. They like to tell us what their great Aunt Gertrude had and how it affected her. None of these things help. What helps are adverbs and adjectives to describe what's going on. So my primary role is helping each one of you figure out what the person has so we can deal with the problem. After we've determined what the pain generator is, we have several options, and we all know that what we offer in the form of occupational therapy and speech therapy is of absolutely vital importance. Cognitive behavioral therapy, extremely important. Encouragement, reinforcement. Nobody hurts if they're happy. So we also have to worry about their mental fitness as well as their resiliency and their overall strength when it comes to the challenges they have. One of the risk factors, for example, for opiate abuse is whether or not people were psychologically harmed before their 18th birthday. If that happens, this puts you at a low risk level of abusing opiates on the spot, regardless of anything else, whether or not you have a history of alcohol or drug abuse, or whether you have a history of depression. Just being harmed as a little person is going to put you in bad stead. And so we need to accept the fact that it is entirely a mind-body experience. So now we have the pain generator. We have a group of professionals who are all going to get together to help the person focus on the pain generator as well as how to interpret their discomfort. And we're going to start with all the best practices, which are what you do. Physical therapy and occupational therapy and cognitive behavioral therapy are 1, 2, and 3, and we figure out how we're going to apply this stuff right away. So we're training the patient, we're educating the patient, we're creating a home exercise program for them, we're showing them what they can do, we're having them focus on function instead of pain. What happens? Well, we get stuck. Or what happens if the patient's pain is so acute they can't participate? Or what happens if the patient has so poor resiliency that they need a little bit of help? This is where the pharmaceuticals kick in. So when it comes to pharmacology, we want to avoid over-medicating people. We generally start with the lowest level and work our way up, as opposed to physical therapy and occupational therapy, where you start with the best choices and work your way down. When it comes to medicine, we start with the least invasive and work our way up. And so there's nothing wrong with reminding people that Tylenol is very good for bone pain. There's nothing wrong with reminding people of the importance of icing and the importance of stretching and the importance of meditation, mindfulness. And so this is where we focus. We also focus on behavioral modification. What sort of things do you do that aggravate your pain? I'm not entirely sure how, but for some reason, whether it be through mentoring through their families or through the commercialization of healthcare on TV, people genuinely believe that recovery is a passive process. And so just reminding them that if it hurts to sit, don't sit, has some value. One of my favorite things to say to people is, it's no different than sticking your finger in your eye. It hurts to stick your finger in your eye. Please don't stick your finger in your eye. And the first thing you do is you pull your finger out of your eye, and that's good, that's a great start. But your eye's still going to hurt. Don't expect 100% recovery after removing your finger from your eye. You can expect 4 or 5 days of discomfort now that you've aggravated the chief complaint. So please don't put your finger in your eye. And when you do, expect to have a consequence for it. Patients need to have a realistic expectation of what their recovery is going to look like, and the recovery is going to be a waveform, and you all know this. But sometimes we forget to tell the patients, and it's really important that we all sing from the same songbook. When we escalate the medications, we do so not so much because the medications are failures, because they're not. It's important that we try simple things first, because that's how we know whether or not simple things were sufficient, right? That should make sense. The next step in medications are simple pain management like NSAIDs, where we start with ibuprofen, and then we can consider topical creams with NSAIDs in them. We do this stuff judiciously because some NSAIDs are very, very difficult in the stomach. I prefer the COX-2 inhibitors, such as Mobic or Celebrex, Mobic being very inexpensive and a great med for this. But it doesn't matter what the NSAID is because they're brutal on the kidneys. So I like to pulse them. You won't read about pulsing medications in any pharmacological text except for maybe steroids. But I like to pulse NSAIDs 10 days on and 10 days off to see if we can wean them off as quickly as possible. And they don't replace icing. And patients don't like to ice, but it's important to ice. I do tell the patients it's important to heat, but only if under the guidance of your therapist, because they're heating stuff in order to facilitate range of motion. And you don't want to heat at home, because often people overheat and they'll just cause themselves all sorts of grief. I do warn them about giving themselves frostbite, so please remember to give people advice on not getting frostbite. If we have to leave the NSAID family for pain management, then we are sort of funneled into the opiates. We do our best to start with the simplest ones, tramadol or Tylenol 3s, knowing that the side effects for these are what you all know, constipation, and they just simply increase the risk of people hurting themselves. They do not increase the fall risk, but they do increase the fact that if we dull their discomfort, they'll just make bad choices and they'll continue to hurt themselves, like they'll put their finger back in their eye. And so we do want them to have a certain amount of discomfort, and they need to know that there's a certain amount of discomfort with life, and this is just the way it is. And so we don't want to over-medicate people. But if we do have to go down the opiate road, we do typically try and keep it under 5 to 10 days. Most people who've had surgery are offered opiates, and most people discontinue them before 5 days. Those people who need these things longer than that, then we start thinking about rheumatic conditions. So people who have psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, almost all of them can be managed with first-line NSAIDs. But eventually then we have to start thinking about referral to rheumatology for DMARDs and immunomodulators. So if you're really struggling and the patient's been trying medications that are higher up, start thinking rheumatic conditions. They're very common, and the older we get, the more likely the person will have an autoimmune disease of some sort. It's not uncommon for patients who are 80 years old to develop rheumatoid arthritis when they've never had it before. It'll be low grade, but they respond really well to things like methotrexate and Plaquenil, so always keep that in the back of your mind. Also recognize too that even though historically we've treated many rheumatic conditions as being a radiological diagnosis, there's lots of research now that shows, for example, ankylosing spondylitis does not have to show sacroiliitis on the imaging. So if it's a young man who constantly has SI joint pain for no particular reason, you should have a high index of suspicion that they have a rheumatic condition of some sort. Once we get to the point where we accept the fact that they're going to be on some sort of chronic pain medication, we start thinking about things like Cymbalta. I'm a big fan of Cymbalta. Cymbalta is great for managing and modulating pain. It is an antidepressant. I warn the patients that they're not getting it for depression. They may already be on an SSRI or an SNRI, and so that kind of complicates things a little bit. And so if that's the case, we'll just increase the antidepressant medication they're on, because they all modulate pain somewhat. But Cymbalta is a really good choice, and it's really easy to manage. Patients won't notice a big significant difference with Cymbalta right away, not like the sort of bang for the buck they get with opiates, so they'll wonder if they have any purpose. For neuropathic pain, we start considering the neuromodulators such as gabapentin, Lyrica, and we would start those if we know for sure it's neuropathic before we go on to the Cymbalta. Again, it's all about the pain generator. And people are allowed to have more than one or two pain generators, so that's a consideration as well. When people have had some chronic pain for more than 6 weeks, we now have to start considering things like imaging. It's important that if the patient hasn't had imaging after 6 weeks of continual pain, that they get some sort of imaging. We typically start with plain films. Now they should have imaging if they already had some sort of event where, like, they had a fall or they have a history of metastatic disease, or they have a history of an infection. But if that's not the case, if it's chronic pain, we need to start with plain films. We'll work our way up the algorithms brought by the American College of Radiologists for CT and MRI, based on their discomfort if it continues. Also, if they end up going on to spinal interventions, we have to have an MRI just so that we can see what our targets look like before we put a needle in anywhere. You're probably mostly interested in all the fancy cool stuff like the spinal intervention, so I'm going to put a bookmark there, and we'll talk about that more later. I want to continue to hammer home the psychosocial part of things. If it's a workers' comp injury, don't forget to consider the yellow flags. Always look to see if there's some sort of issue that offers secondary gain. And we don't have to confront people on the secondary gain. That's not what this game is about. It's just a recognition that if it's there, that we have an obligation and a duty to save healthcare the costs of chasing red herrings. So if they don't like their job, or there's a chance that they'll receive a compensation package for being injured at work, or they have a history in the past of not keeping jobs for a long time, their attitude about returning to work is poor, they have little family support, these yellow flags have to be considered and have to be addressed. We just don't have to make it all that aggressive. And if any of us finds out this stuff, we need to make sure we report it to each other so that we have a heads up. Let's not reinvent the wheel here. If your spidey sense starts to tingle about something, share it with all of us in your note. Certainly you don't want to be mean or cruel, but you can quote the patient, for example, and those quotes will give us a hint at what's going on. There's a fine line between being mean and being factual. Try and find that fine line. You will find in my notes that if I have any of these suspicions, that they're there. You just have to read the assessment plan, and that stuff is there. I spent a lot of time talking to medical residents about the importance of the physical exam. That'd be a waste of time on each and every one of you. You guys spend all your time in your physical exam with the patient, and I truly appreciate this, and I want to take this moment to say thanks for doing that. It saves me a great deal of work, all the hard work you do during the physical exam process. And it saves me a great deal of work when you find stuff that I've missed. So I just wanted to take a few seconds to say thanks for that. Well, I guess at this point I can actually move on to the different interventions that we do in the outpatient setting, and the risks and benefits of all the above. Recent large meta-analysis came out about steroid injections. I'm sure you've all read it, which show that 8% of all patients who get knee, shoulder, hip injections are on the train to having total replacement. This is higher than people who don't receive injections at all. And I don't think this should surprise anybody. We've known all along that Marcaine is cartilage toxic. And we know that steroids slow down the healing process, so we shouldn't be surprised. And we also know, too, that now that we've blocked the discomfort in that particular joint, if the muscles balancing that joint aren't well balanced, well, now we're just beating the heck out of the joint, right, and we're covering stuff up for the next 4 to 6 weeks. So we haven't done anybody any favors. Now, if doing these injections help facilitate their physical therapy, help them go on to Tai Chi and yoga, and some sort of home exercise program where they're sweating 3 times a week for 30 minutes, well, maybe it's worth it. And so those patients who actively go to protect the joint by making things stronger are doing us all some good and keeping themselves out of that 8%. But those patients who go back to their sedentary lifestyle, they're just setting themselves up for more troubles later on. Most of the large joint injections that we can do through manual palpation. I live and die based on my understanding of anatomy. Needle placement is entirely your understanding of anatomy. If necessary, we can do injections using ultrasound guidance. This makes it much easier because we can actually see the needle enter the tissue. We can watch it go through the different planes of fascia and into the actual joint. Our office is well trained in ultrasound guided injections, and if you think that a patient would benefit from an ultrasound guided injection, make it happen. We do a lot of trigger point injections too, but as each of you is aware, trigger point injections work so much better if they are done immediately before physical therapy to stretch out the muscle. So always try and arrange your muscle treatments. If you think trigger point injections are going to help with the office in the outpatient setting, to get the trigger points done just before you stretch. Makes your job easier, we get better bang for our buck. We always educate people to stretch after we do the trigger point injections, but nothing beats the work that you do. In our region, we have some therapists who do dry needling. That's awesome because all the studies show that whether we inject Marcaine, normal saline, or nothing, that if we hit the trigger point, we get the same result. So knock yourself out. If you're qualified in doing dry needling, or if it's any way I can support you in doing dry needling, hooray, hooray. This is one of the greatest ways to look after trigger points. And as you guys know from all of Travell's great work, I have two of the family's tomes in my own collection, that myofascial pain is a very, very common thing in our environment. And just getting rid of this particular discomfort really helps people move forward. Not everything is some sort of major calamity, and trigger points are very easy to resolve, and we can teach the patients to manage these things at home, which you do all the time. The other injections we do in the office, aside from manually palpated, with the ultrasound machine we can do shoulders, we can do bicipital groove, elbows, ankles, knees, of course, including Synvisc, and hip. All these things can be done in the outpatient setting under ultrasound. It's relatively straightforward. Well, I guess I can move on to the thrills and spills of spinal interventions. So basically, the purpose of the spinal interventions is that's not the cure. People heal. Biological systems heal. The body's going to heal. But sometimes people need 4, 6, 8 weeks of pain relief in order to facilitate the healing. So if it's a true radiculopathy, if you can demonstrate the dermatome with your finger, and the patient can demonstrate the dermatome with their finger, then epidural steroid injections are spectacular. If it's not a true radiculopathy, the epidural steroid injections aren't quite as spectacular. If the patient has spinal stenosis, the odds of me being successful with an epidural steroid injection are significantly less. Some patients do report relief with epidural steroid injections with stenosis, but the percentages of improvement are significantly less than true radiculopathies. If you have a true radiculopathy, I'm going to turn it off by reducing the inflammation around the nerve. I will turn it off between 4 to 6 weeks. If, as you know, true radiculopathies, 60% of them respond within 6 weeks, so that might be all they need. 90% respond within 9 months, so maybe they'll need a couple of repeat epidural steroid injections. But most people, it's a 1 or 2 thing. If they have a radiculopathy longer than a year, this is time to really, really seriously consider surgery. And of course, as you know, if they develop true motor weakness, we absolutely have to evaluate them for potential discectomy, because we cannot have permanent damage done to the motor part of the nerve root. Most radiculopathies in the C-spine, as you know, are sensory and not motor. So if we have motor weakness in the C-spine, that absolutely has to be worked up for relief, because we cannot let people get to the point where they develop a myelopathy. Myelopathies cannot be reversed. All the surgery does is prevent them from getting worse. And so that kind of weakness is permanent. You notice upper extremity weakness, you get help right away. And that reminds me, as a sidebar, we can also do ultrasound-guided injections for carpal tunnel. So if the carpal tunnel is moderate or less under nerve conduction study, we'll do steroid injections for that, and that often helps people a ton. That and behavioral modification splinting, as you know. So, so that's epidural steroid injections 101. Find me a dermatome, tell me the level, I'll know what to inject. It's really that simple. Tell the patient to expect relief for 4 to 6 weeks. Also let them know that it's not the cure is the body will repair itself. All I'm doing is giving them some relief for that period of time. Stenosis doesn't work so well, but we typically do a series of injections for stenosis before we send them off for laminectomies. Laminectomies are the definitive treatment for spinal stenosis. And we want to get to before they get to the point where they develop permanent weakness. Although the weakness, when I say that, is not permanent. Before they develop lower extremity weakness, they can get that strength back, but not in the neck. Okay, good. Got that covered. Please do not adjust the color on your screen. I am wearing a different shirt, as this recording was interrupted due to memory space issues. So I will resume from where I left off. The next thing to talk about is medial branch blocks and facet ablations. The purpose of medial branch blocks is to determine the pain generator, or which facet is causing the person discomfort and from their facet syndrome, and the whole point of the radiofrequency ablation is to burn the nerve. It does not change them physiologically otherwise than burning the medial branch. The problem with the facet is still there, it's just the signal does not make it to their brain. So most people will notice a significant improvement from radiofrequency ablations for at least 6 months, but often up to a year. Seldom do I have to repeat radiofrequency ablations. If the person's feeling more comfortable, they'll participate in therapy more, they'll do their home exercise program, they'll walk more, and these are the sort of things that are really necessary to help manage their low back pain or neck pain or upper back pain. And by being more active, Tai Chi, yoga, because they're no longer in pain, they will build up the strength necessary to prevent the facet syndrome issues to come back. Other interventions that we offer, and if I repeat anything, it's been a couple of days since we did the initial recording. Other interventions we offer is sympathetic blocks for complex regional pain syndrome. Sympathetic blocks are relatively straightforward. Some complex regional pain syndrome can be turned off or calmed down by blocking the sympathetic chain. We just simply put a little bit of steroid and Marcaine up against the sympathetic chain under fluoroscopy, and they'll notice it changes in their lower extremity on the spot. We also do SI joint injections under fluoro if we can't do the SI joint injection under ultrasound in the office. This is typically meant for bigger people. And last but not least would be office injections such as Botox for spasticity, Botox for migraines. This sort of stuff is relatively straightforward. The idea is the botulism toxin poisons the muscle and prevents the muscle from doing its job. The muscle will regrow the acetylcholine receptors, and therefore Botox only lasts for 12 to 14 weeks. We can repeat the Botox injections every 12 weeks because if we do them more frequently than 12 weeks, they'll develop antibodies, but at the 12-week mark, they will not develop antibodies to the botulinum toxin. This is highly effective for spinal cord injuries and traumatic brain injuries, or people who have recurrent migraines that are caused by muscle contraction headaches. So I think that pretty much covers everything that they wanted me to cover in this 30-minute talk. I wish I was there to answer questions. Wish I was there to ask a few questions of my own. I do want to take this time to say that I feel very, very fortunate to work in a region with such a deep talent pool. Most of the conditions that come into the outpatient setting can easily be managed in Southern Illinois in-house. Gone are the days that we have to send people off to Paducah or Cape or off to St. Louis, and that's because of your skill set. If you have any questions, you can always reach me via email. I prefer the in-basket and Epic. You can also just call the office. A lot of you already do this, and I truly appreciate it. Have a beautiful day.